Master of Medical Science, spesialis patologi klinik, kami persilakan kembali untuk memimpin jalannya sesi berikutnya.
Baik, terima kasih kepada pembawa acara atas waktu yang telah diberikan. Ladies and gentlemen, welcome back. We will move to the next session of our workshop. In the second workshop in day 1. So far, we have discussed about the immunophenotyping in acute leukemia and also mature myeloid or lymphoid neoplasms. So our next session take us one step further by exploring how immunophenotyping can correlate it with the sequencing and molecular data in the clinical practice. This is my great pleasure to introduce our next speaker, Dr. Lee Sirying. Dr. Lee Sirying is professional position in Senior Consultant Hematologist at the Division of Hematology, Department of Hematology Oncology in National University Cancer Institute, Singapore, and Department of Laboratory Medicine, National University, Singapore. With the many experience in the laboratory, especially in the hemato and oncology, so in this time, Dr. Lee Sirying will present about bridging the gap, correlation flow cytometry in sequencing data through clinical case studies. It is a great honor to have Dr. Lee. Okay, the floor is yours.
Hello, good afternoon. Can you hear me? Okay, good afternoon, everybody. I'm Dr. Lee, and I'm very happy to be here. So I would like to thank the organizers for inviting me to do this talk on flow cytometry. So I'll be speaking in English, and feel free to ask questions at the end, or to raise any questions that you may want at the end of the presentation. Okay, so just a disclaimer. So I'm a hematologist, and for hematology in Singapore, we are actually trained in both diagnosis hematology in the clinical pathology laboratory, and we also learn how to do the treatment to the patient. So what I hope to do is to bring some perspective on what are the interrelationship between the diagnosis as well as the prognosis as well as patient treatment. So what I'll do today, cover in this talk, is that I will be talking about the immunophenotype of distinct acute myeloid leukemia genetic subtypes. And I will touch on the rare AML subtypes for a little bit. And the slide is, we are having a technical issue. Let me forward a bit. Okay, so while waiting for the slides to come up, maybe I'll just kind of briefly introduce a little bit about what I'll be talking about. So I'll be focusing primarily on acute myeloid leukemia. As you know, acute myeloid leukemia is the most common leukemia, or the leukemia in adult patients. And it is increasing in incidence with age as the patient's population ages. So I think when we do flow cytometry in acute myeloid leukemia, we are trying to answer a few questions that the doctor or the treating doctor wants to know. So the first and foremost is diagnosis. They depend on the laboratory to diagnose, and then subsequently they want what the laboratory information can give is actually to prognosticate how well the patient will do, and will also give the precision medicine indicating the targets of therapy. And finally, monitoring of the disease is very important to monitor how well the patient respond to chemotherapy. So at the time when we do diagnosis, we really want to answer four major questions. One is, what is the lineage of the abnormal cells we are seeing? Number two is, we need to pinpoint the stage of maturation. Is it a precursor neoplasm, that means leukemia, or is it a mature neoplasm, which means in the B cell and the T cell, it will be a lymphoma. And next, we want to answer, does this population have aberrant? Is it a normal variant or is it an abnormal neoplastic population? It's very important. And finally, we can enumerate the blast very accurately. And then subsequently, for prediction of genotype is important as well, because the genotype will tell us how well the patient will respond, will tell us what type of treatment we need to give. And finally, we can also identify targets of therapy. For example, for CD33, there is gemtuzumab, which is anti-CD33 chemotherapy. We have anti-CD123 for blastic PDCN, and we have anti-CD49 as well. And finally, we can use flow cytometry for minimal residual disease monitoring. After induction, we want to know, okay, a morphology blast is less than 5%, but how much is actually remaining, okay? And usually for flow cytometry, the enumeration, there are two main levels of enumeration we need. For AML MRD, we want to know less than 0.1%. For ALL, acute lymphoblastic leukemia, we want the level of MRD detection sensitivity to be at least 0.01. Okay, so for ALL, 0.01%, and for AML, 0.1%. Okay, so AML is a disease of somatic mutation. So I think you'll be very familiar with this. We call it a multi-hit model of tumor development. So what we are saying is that there is usually a driver mutation followed by very small minor mutations in the clones. So a lot of times the driver mutation clones tend to be quite big in percentage, whereas the subsequent mutations may be present in different parts of the leukemia, meaning to say of the leukemic cells, not all of them actually have the same mutations. So when we do NGS, we have to remember that whatever result that we get may not actually come from the same leukemia cell, but it is holistically part of the malignancy itself. So sometimes when we give treatment, we may eliminate part of the leukemic clone with targeted treatment, but other clones within the leukemia without that specific mutation may actually survive the chemotherapy and cause relapse. And so along the way, after treatment, there might be evolution in the type of mutations and evolution in the percentage of the mutated clone that we see. And that is basically what we will see when we do NGS. So why are we so fixated on cytogenetics and mutations? Why is it so important? So this data is from 30, 40 years ago. At that time, they only have cytogenetics. They look at the chromosomes. They can only see big effects, very visible effects on the chromosome in order to track what mutations a patient has. So the classic one are listed here. The top few lines shows you how well the patient is going to survive with chemotherapy. So you can see that those on the very top will survive very well. And what kind of cytogenetics are the ones that survive very well? Those that are translocation 821, the 1517, which is the acute promyelocytic leukemia, and those with inversion 16. With just chemotherapy alone, they can 70 to 80% of them can survive. Now, compared to those with complex karyotype, if they have 3 or more abnormalities in the karyotype, or they have deletion 7 or monosomy 7, loss of chromosome 7, or they have a translocation between chromosome 6 and 9, etc. With chemotherapy alone, they have a very poor prognosis. Their long-term survival is less than 10%. Whereas those in the middle come under others with an intermediate prognosis. So those that are normal cytogenetics, that means 46XX, 46XY, they belong to the intermediate category. And in the intermediate category, that is when people start looking at the molecular mutation level. NPM genes, FLT3 genes, and AXXL1 genes, and a whole list of other genes to try to tell us how they were going to do. Do they need a bone marrow transplant or do they don't need a bone marrow transplant? So I won't go through all this here. In the NGS, they will cover majority of these myeloid genes. But what I want to show you is the one on the most on the left is the FLT3 mutations, NPM1 mutations, DNMT, NRAS, complex TET2, etc. And those are the more common type of myeloid genes that AML patients will have. Okay? So for FLT3, there is now a FLT3 inhibitor. I will talk about it later. All right. So with abnormal eosinophils, then APM AML NPM1 with or without FLT3 mutation, you have the cup-like nucleus, M1 or M4. And finally, if you have acute megakaryoblast leukemia, you see this blast with black cytoplasmic blabbing. And it is associated with translocation 122 and also chromosome inversion 3. All right? And all those as well. If you see on the right side, those with KMT2A, which is the MLL gene, now they call it, the new nomenclature is KMT2A. Old nomenclature is the mixed lineage leukemia MLL gene on chromosome 11q23. It typically presents with AML M5. So I think what we are saying is that flow cytometry can predict what genotype is going to be, and I will show you some cases. So this is acute promyelocytic leukemia. On morphology, it is as such. So what is the unique feature on flow cytometry? Now, so the most important finding on flow cytometry is that it is CD34 usually negative, CD117 is usually weak, and HLA-DR is usually negative, and 64 is moderately strong. And so when we see this, we can actually be quite confident that this is acute promyelocytic leukemia. So there are some minor things, such as, for example, in a microgranular variant, CD2 and CD34 might be positive, and CD56, if it is positive, may carry a worse outcome. Interestingly, what we observe is that some of them have basophilic differentiation, but it doesn't make the diagnosis basophilic leukemia. No, it's APML. Some of them will have some CD203 and CD123 and expression as well in a minor subclone. All right. So yeah, so those are the main thing. So bear in mind, it is a CD34 NEC, 117 NEC, and DR NEC case. So this is a very typical APML. So the red color, you can see the 34 on the left, it is very low. And the HRA-DR, sorry, the CD34 is very low, DR is negative, and the CD117 on the top is actually reduced, all right? And what we know is that the CD15 tends to be very dim, which is abnormal because normal promyelocyte should be 15, very bright. And you can see CD64, it is expressed. So just remember this phenotype. So actually on flow, there are certain AML that can mimic APML phenotype. That's very important to know about, so as not to make incorrect diagnosis. So the most important is the AML with the NPM1 mutation, all right? And sometimes AML with FLT3 mutation without NPM1 might show it, and the AML with KMT2A rearrangement is an uncommon cause. So what we'll talk about is the first one on top, the one with the NPM1 mutation. So what is NPM1? NPM1 is a driver mutation for almost 40% of AML cases. So if you do all your AML cases, about 40% likely to have the NPM1 mutation. And they are usually with the normal cytogenetics. So it is a multifunctional protein and is involved in the cell cycle. I won't go through too much about this. And you know the cup-like nucleus. So what we observe is that in about 30% of NPM1 mutated AML, they have an APML-like phenotype. Like. Why do we say it's like it? And that's because they are CD34 negative, HLA-DR negative, and that is the thing. Whereas in most typical AML, they are usually 34 positive and HLA-DR positive with positive 117. All right. So as you know, CD34 is a blast marker. So most of the AML M1 and M1s and M0s, they are 34 pos, HLA-DR pos. But the NPM1, like, they can have DR negativity. And so they appear a little bit like APML. Has been and have different blast phenotype. Okay, so what we are showing is that if you look at CD117 versus DR, many cases have the blue color phenotype, which is when the HLA-DR is negative and the 117 is positive to dim, and the 34 is negative. So bear that in mind. Okay. So similarly, this is just another case to illustrate this. So 34 NEC, DR NEC, and 117 positive, which is in the red. Okay, this is a case with a FLT3 mutation. So again, you can see that the DR is dim, 34 is negative. And what distinguishes this from APML, is that 64 tends to be negative in the NPM1 cases, as opposed to APML, where 64 is usually positive. Okay, so in NPM1 AML, CD64 is negative, whereas in APL, CD64 tends to be positive. So again, how to differentiate between APML and NPM1 AML is with the monocytes. In the classic APML, you will not find any monocytes. There will be no monocytes, very few, if you even see it. But in the NPM1, there tends to be some residual monocytes present. And the monocytes tend to be a little bit aberrant in the sense that they increase in the IRAM before they increase in 14. So there is a little bit of an aberrancy in the monocytes as well. Okay, So this is just a table listing how to differentiate APML from the CD34 NEC, HLA-DR NEC AML. And I have mentioned already, I just highlight to you that for the monocytic component in APML, no or very reduced, whereas in the other type of AML may be retained and often aberrant. All right. And in APML, CD15 is absent, whereas in the AML, it may be partial and weak in expression. And CD64, I mentioned already, positive in APML and negative in the AML with MPN1 type of mutations. Okay, so why are we so, why is the treating doctor so obsessed with, finding FLT3 ITD mutation? And that is because there is a drug that is targeting the FLT3 kinase that is very effective, and it is a game changer. So the standard of care in a lot of places is to do the chemotherapy and add the medications such as midostaurin and quizartinib. Those are newer drugs. So sorafenib also the FLT3 mutated AML, and is already a generic drug in its, it's generic actually. All right, I'll come to the next type of leukemia, and that is the 11q23. So 11q23 is a poor prognosis indicator. The patients tend to be monocytic and they tend to relapse quite easily. So there are many fusion partners with KMT2A. KMT2A, if it is translocated with 1119, they tend to have a more mature monocytic subtype, phenotype. In the old classification, it will be the AML M5B, the monocytic leukemia. Whereas M5A, if you have a translocation between 9 and 11, most of the time they have an immature monocytic phenotype, and it looks like a AML M5A. All right. And to differentiate between M5A and M5B, I think morphology will be quite obvious, because you will see that the M5A is usually monoblast. In M5B, M5B is more pro-monocytes and monocytes. All right. But some of these cases can have a phenotype where it is CD34 negative and APML-like, in the sense that it's 34 negative and HLA-DR negative, with two different populations, as seen by the plot in the middle of that one positive with very high CD64. Those are the monocytic component. All right. Okay. So, and what is interesting is that for KMT2A rearrangements, when they relapse, sometimes they get immunophenotypic change. So in 42% of relapses, they show a major shift in the immunophenotype, and the immunophenotypic spectrum of AML with KMT2A rearrangement relapse is a BALL, or they present as a BALL, then they relapse as a monocytic leukemia. So sometimes the clinicians will ask us, did we get the diagnosis at the start correct? And then if you look back, it's usually correct. It's because of the plasticity of the leukemia cells. Okay. So usually we will, this can be seen in the cytogenetics, but we can also do a FISH. So this is a break apart FISH, meaning to say a break apart with a partner chromosome. You can either do a break apart FISH, or you can do a fusion FISH to look specifically for which chromosomal partner. A break apart FISH just tells you that the MLL gene is translocated. It doesn't really tell you which fusion partner it is. But So there are different configurations of the FISH probe. Okay, so FISH is quite useful to confirm this KMT2A mutations. So again, is it important? Yes and no. There is some drugs under development. So the KMT2A mutation works by the menin pathway, and it activates this leukemia process. So there are new medicines that actually inhibit menin, which is there on the left. Menin inhibitors blocks the MLL binding site, resulting in downregulation of the host gene, and it will cause the leukemia cells to differentiate to become neutrophils, kind of like treat the leukemia, all right? So there's some potential drug target for that. Okay, so I will come to the next one, which is 821. So 821 is quite often in younger AML cases. It has a good prognosis. With chemotherapy alone, the cure rate is quite high. So for this one, it's typically a AML M2, as you know, and what is unique is that it has co-expression of B cell markers. So whenever we see a M2, and then we see the myeloblasts, 34 pos, 117 pos, HLA-DR pos, 13 pos, 33 pos, but also expressing PAX5, CD19, and cytoplasmic CD79A, especially CD19. We have to think, is this a 821 AML? And we should not mistake it for biphenotypic leukemia. And this is just some pictures to show you. There are certain scoring systems, so there are a lot of publications there. If you want to go into this publication, you can look at it. They even come up with a scoring system to say this is likely to be 821. All right, so you can read here what are the scores that go in, like CD19 expression, CD79A expression, CD56 expression is also very typical of this AML. So whenever we see this, we're like, oh, okay, nice. It's a full, what we call a full house aberrancy, most likely 821. Then we look at the cytogenetics, then we say, yeah, correct. We were right on the immunophenotyping. Okay? So what I'm trying to say here is that sometimes, even for us, we mistake the 821 to be myeloid B biphenotypic. That is erroneous. You shouldn't, because this is just treated as a AML. It's not a biphenotypic. So I just put here, I think Dr. Yeti did go through this, so I won't go through this. I'm just trying to say that you must not mistake 821 AML for biphenotypic AML. Okay? Okay. How about inversion 16? I think inversion 16, not so much of issue. Inversion 16 is usually myelomonocytic, so you will see the blast, and then you will see the monocyte component more than 20%. So on monocytes, how do we identify monocytes on flow? Very easy. 64 bright, HLA-DR pos, and 33 is usually very bright also. So if you go with that, it will almost certainly. Now, CD14 is a monocyte marker, but it comes out in the later stage of monocytes. So in monoblasts, the 14 might be negative to a little bit dim, okay? But they will almost always be very bright for CD64. That's how you identify. And, okay, so, and then you might see some eosinophils, of course, right? Now, I will come to this CEBPA mutation. So what is CEPBA mutation? CEBPA is actually quite common in young patients. And what is interesting here, so we have got two alleles of CEPBA, right? Two alleles of the gene, one from the father, one from the mother. In some patients, they inherit a CEBPA mutation. It's an inheritable germline mutation. And then when they become older, the other allele acquire a somatic mutation, and then they become biallelic, and they develop AML as a result. So there is a very classic immunophenotype that we can identify based on aberrant CD7 and aberrant CD15 expression. So in CEPBA mutations, I will talk a little bit more next tomorrow, is very unique. Some say it is good prognosis, some say it's bad prognosis. But what is the difference? I don't think I can talk too much about that today. I will touch on this tomorrow, okay? Is it good or bad? Is CEPBA good or bad? We'll talk about that tomorrow. So what we can see on the flow is that typically it is 34 pores and they have an aberrant CD15 bright, 7 bright expression. All right, so 15 in normal myeloblast, CD15 is negative to low because 15 is a mature marker. It comes out on promyelocytes and beyond. Usually in myeloblast, no 15. But in CEPBA, yes, the 15 is positive and the 7 is also positive. Okay? Okay, so I will talk about this. This is, is there a difference between monoallelic CEPBA mutation or biallelic CEPBA mutation? Yes, there is some difference. I'll talk about it tomorrow. Okay, so I'm not sure whether I have enough time, but I will talk about plasmacytoid dendritic cells. I'm not sure if you normally will see plasmacytoid dendritic cells or blastic plasmacytoid dendritic cells. Now, this entity causes a lot of confusion because it is a minor subset, minor population in the normal marrow. So in all normal marrows, we have plasmacytoid dendritic cells. So what are dendritic cells? Dendritic cells are antigen-presenting cells that are less than 1% in the bone marrow. And they are derived from hematopoietic cells, all right? And they are characterized by a very high CD123 expression. So if you look at the plot on the left, if you do CD123, the plasmacytic dendritic cells are in green. They are HLA-DR bright and they are 1, 2, 3 bright. Whereas basophils are 1, 2, 3 pos, HLA-DR neg, and it is in purple there. And why is this important? And that's because in some acute myeloid leukemia cases, the plasmacytic dendritic cells become increased in number. Okay, so the normal percentage is less than 1%, but we have seen AML where it goes up to 15%. And why is that important? It's important because if the dendritic cells are increased, it tends to denote a fairly poor prognosis. And I think what I'm trying to say here is that the dendritic cells can actually look a little bit like lymphoblasts. So if you look at the picture there, AML with PDC increase. Majority of them are monoblasts, but there are some cells with a elongated and taper tail. So dendritic cells, because they are antigen-presenting cells, their cytoplasm tends to be long and taper like that. And they might be mistaken for lymphoblasts, all right? And their unique feature is that their 1, 2, 3 is very bright. CD123 is very bright. And people have found that if the dendritic cells are more than 2% in the flow, it is associated with RUNX1 mutation in 60 to 70% of cases. And RUNX1 mutation carries a poorer prognosis for the acute myeloid leukemia, like less likely to go into remission and things like that. And nowadays, there is anti-CD123 monoclonal antibody for treatment. And people are studying the use of anti-CD123 for treating no myeloblast. Myeloblast is not increased. So on the flow, it will be very easy for you to differentiate BPDCN from AML with increased PDC. Okay? So I think I only have about 5 minutes, so I will skip through this. This is just to show you the picture. And the PDC, which is in green. So gray is the blast, green, CD123 bright, and CD34 neck. That is the PDCs. Okay. So this is another case. Okay, so finally, I will talk about acute basophilic leukemia. So to be honest, if a person is diagnosed with acute basophilic leukemia, we know that this is a generally poor prognosis, very rare AML. The treatment will not be very much different. We will treat as for a usual AML, and we hope for the best. Okay. So, but what is interesting about this is that the flow and morphology can actually identify very well. So this is a case from our institution where the basophil up there in the picture, there were a lot of basophils, and you can see and on the flow, basophil, what is the basophil phenotype? The basophils are 1, 2, 3 positive, like what I mentioned, but they are HLA-DR negative. Okay, negative for HLA-DR. CD22 tends to be positive on basophils. All right, so you might say, hey, CD22 is a B cell marker, but actually it's that isotype is actually expressed on basophils. So 22, and the unique thing is CD203C. So if you have CD203C, then it will be useful to confirm that it's basophils. But if you do not have 203, it is quite, you look at the morphology, the CD123 is positive, HLA-DR neg, you can be quite confident that these are basophils. So anyway, this patient had myelodysplastic syndrome before, and then he progressed to acute basophilic leukemia. The basophils were almost 70 to 80% in the blood, and the patient had very complex phenotype. And this carries a poor prognosis, and true enough, the patient passed away within 1 year of the diagnosis. Okay? I think I'm at 3:30 already, so I'll stop here. 5 more minutes? Okay, sure. Okay, so I think maybe I will just talk a bit about megakaryoblast leukemia, because I think megakaryoblast leukemia is quite uncommon, but how would I say? It is nice to diagnose. It is essentially a flow diagnosis. Why? Because yes, usually on the morphology, you might see the blast with the cytoplasmic projections, blebs. However, not all of them have the blebs. Then you also look at context. Most common in Down syndrome children, but also is more common in children. In adults, it might be from it might be de novo, or it might be from an underlying MDS. So some of the cases we have seen in adults is when a patient had MDS and then progressed to become the acute megablastic leukemia. So what we do is that the problem with acute megablastic leukemia is that to confirm, you need to give megakaryocyte markers like CD61, CD41, CD42A, and CD42B. So that is so many markers, right? It's very expensive. But however, even for us, we don't always run this. We will run a basic panel, and what are the phenotype that give us a clue that this could be megakaryoblast leukemia. So essentially, they are CD33, they tend to be CD13 and 33 tend to be very low. All right. And CD117 tend to be negative. So, okay, so there is a characteristic pattern. You have myeloblasts, all right. 33 is there. You don't have any B or T markers. So you have CD33. But then they have a very funny, not quite there phenotype, like CD13 is low, CD117 is low, and CD36 is high. I'm not sure whether you run CD36, but CD36 it tends to be high, and 56 tends to be high. Okay, so if you have acute myeloid leukemia that is 34 pos, but 13 is very dim, 117 is very dim, then and 36 is pos, then okay, then that's when you suspect, hey, maybe this is megakaryocytic leukemia. Then you can add in the megakaryocyte markers like CD61 and CD41, all right, to confirm, all right? Okay, I think I will stop there. I think I will stop here because of the interest of time, and I also want to give some time to the next speaker and for some questions. Okay. Thank you.
Okay, thank you very much to Dr. Lee for the insightful presentations. Okay. So we are moved to the next sessions. Now this is the where next generation sequencing becomes increasingly important. So it's my pleasure to introduce our final speaker for this session is Yang Chen, PhD. Yang Chen, PhD is a professional position in the nano-digbio biotechnology. When education background is postgraduate education at Wuhan University, biochemistry and molecular biology. And today she will guide us through the next generation sequencing in hematology malignancy. To Yan Chang, PhD, thank you for joining us today. The floor is yours.
Thank you.
Okay. The introduction. Hello, everyone. I'm Yang Chen from the Nano-Digbio. I'm based in China. Actually, it's a great honor to be here to give this presentation to introduce the significance of NGS. Here, experienced experienced experts here, and today I'm more like to introduce a new technology to help in the clinical today's introduction. First, I will begin with the background. So, for the common solid tumors like the breast cancer or lung cancer, we can also see that a lot of the hematological malignancies also lead to the high incidence and mortalities, and it has lead to the high burden to the health globally. And for the blood cancer, it actually originates from the abnormal proliferation and the differentiation of the hematopoietic cells in the bone marrow and the blood, etc. And normally, for now, a lot of technology has been used to check with the phenotype to do the combining diagnostics. But now we also know that a lot of such kind of the blood cancer is due to the solid tumor because of the solid mutations. And here we would like to give you two examples of the most common hematological malignancies. One is the multiple myeloid, and we can see here about the phenotype. But when we check with a lot of the publications and some of the database, we can also see that a lot of the genes, the pathways has plays a lot of important roles in the function when which will lead to the disease happens. And here we show you some of the data, shows that a lot of the biomarkers, the molecule biomarkers, gene mutations, can used for such kind of the applications for the combining diagnosis. And besides for this one, also is the similar for the myeloid. So actually for now, a lot of kind of the products based on the different kind of method, like the PCR, NGS, etc., has been used to check with the different kind of the mutation, the cancer-related drive genes mutation to check with whether there is a kind of the blood cancer and whether there is kind of the drug therapy site mutation here. And also, beside of such kind of the cancer drive genes mutation, we would also like to introduce other two kind of biomarker, which also are very important for the malignancy for such kind of the detection. One is the IGTR. We see the TCR, BCR receptor in the immune system. It will have the arrangement and to organize such as the VDJ fragments to ensure that the diversity of the antigen receptors in the normal immune response. And sometimes if the genes has some mutation or the rearrangement has some abnormal situation happens, it will need to that maybe it will have the abnormal proliferation of the one kind of the T cell or the B cell, and also it will have such kind of the abnormal will need to like the B cell or the T cell, the polyclones and the monoclones, the leukemia, in female, and if we can check with such kind of whether there is a high proportion of one kind of the monoclones, and we can distinguish about whether it will to check with to combine with this kind of information with some phenotype together to distinguish between different kind of the cancer type. And also, besides that, we can see that if with the T-cell, B-cell information, we can also assist, because we see that the T-cell, B-cell will have some differences information, and with the T-cell, B-cell receptor the information, we can also determine whether this kind of the blood cancer is the B-cell or the T-cell tumor type. And beside of this kind of the function, for the individuals, we see that the T-cell, B-cell will be specific for different individuals. So actually, besides for the combining diagnostics situation, such kind of the IG TCR information also can be used for the MRD monitoring, actually. And so we see that the TCR, BCR recombination will be very important. And beside of that, for the B cell, such kind of we see that the B cell has some kind of the B cell leukemia, such kind of the blood cancer type. And the B cell receptor itself has to do the arrangement. And beside of that, after that, they also need to be the recombination to do such kind of the switch from the different kind of the immunoglobulin, etc. And with it, during this process, it has to have some double strand break, and during this process, it will have some maybe mistake, and it will the IGH region maybe the most important region, it has to do the break region. It maybe have some wrong with some kind of the drug, the cancer drug genes like the MYC, such kind of the most important genes, and and some kind of factors like the enhancer, like such kind of the function module will increase the expression of such kind of the cancer drive genes. And it will also be a very important reasons that maybe has lead to some kind of the blood cancer just happen. So we say that the IGH, which the double strand break region, will also be a very important biomarkers in such kind of the detection situation. So the information, the gene variation, the mutation, and the IGTR and the IGH are the most important biomarkers for the molecule detection scenarios. And in order to detect such kind of the biomarkers, we see that the NGS plays a very important role. So for now, besides for the blood cancer, the NGS has been used in a lot of the applications like the NIPT, like the solid tumor and the WES, etc., and the pathogen detection, etc. And also there has a lot of the publications and the consensus that say that the NGS also has a very important role in the hematological malignancies that detection scenarios. And actually, we are not just say that NGS is the only technology, only method for the hematological malignancies, because just the background we just show you that for different kind of the blood cancer, the variation map will be very different, and maybe they have the similar morphology, but it will have some kind of the different mutation and the different kind of the drug therapy site. So we would like to involve the NGS and combine with other kind of methods together to give a more precise and a more reliable result in such kind of the diagnosis situation. So actually, what NGS is for the NGS solution, we need to we need to select the most important biomarkers, like the different kind of variations, like IGTR, IGH switch region, etc. And we need to select the most important biomarker for select this kind. And then we need to, based on the region we are interested in, and we can design some the oligo to target this region. And the oligo itself has some biotin modification, and we can use some kind of method to enrichment the target region and to perform the deeper sequence. And with the deeper sequence and the bioinformatic analysis, we can check with the most important biomarkers variation information to get a reliable result. And we can refers to different kind of the database like the ACMG and like ClinVar database, etc. And we can check whether this kind of variation will to be the pathogenic variation or not. And after that, we can use that kind of information to check if that kind of the specific drug can be used, and we can check with which kind of the treatment will be more suitable for this kind of situation. And to perform this kind of NGS liquid-based hybridization experiment, we need to involve a different kind of reagent, like we need to perform library preparation. Actually, this kind of step is because we have a different kind of sample, clinical sample, we need to add different barcode just to give a different kind of the samples an ID. After that, we can involve the hybridization and the panel, the probe is together to enrich the region we want. Actually, because we see that the probe is designed based on the interested region, and the interested region can be a lot, but all kind of the probe can be put in together, which means in one run with the NGS, we can get a lot of millions, we can get 1,000 and hundreds of genes and many kind of variation in one time, in one run with the hybridization. And after that, we can just check with use the bioinformatic analysis to do such kind of variation information, to check with the CMV, indel, and a lot of the such kind of the variation information has been reported, like the different publications, like different kind of the database and the guidelines, etc. So here for the for the hematological disorder, so the blood cancers, we have the developed two kind of the products. One is the nanohema panel version 2. So this kind of products we considers all kind of the common blood cancer type, and we involved a lot of important mutation information we just showed to you, and we developed this one. Another is based on the different kind of the probe design, and this is the Mucala. We call that the specially designed for the AML panel for the MRD detection. And later I will talk more about these two kind of products to give you a new like some kind of tool, some kind of technology in the clinical combining diagnostics. So this panel, it will be a very special panel because actually, as I said, that following the market, a lot of the products has been developed based on the probe design, the hybridization, the liquid biopsies, and they may be only based on the one kind of template. It's only based on the DNA template or only based on the RNA template to design the probe. But for the blood cancer detection, we see that some kind of that, like the CNV, the SNV and indel, such kind of variation, we can based on the DNA template. It will be very good to get the information. But the other kind, like the fusion, maybe we need to combine the DNA template and RNA template together to get more reliable and more precise result. So first, we can check with the DNA tube. So in this tube, we involved the 436 genes, and we cover the full CDS region, which means that we can get all kind of the variation if they happen in this CDS region. And besides of that, we also selected 12 selected intro region. We see that this intro region will be very important, so we selected for the fusion detection, and also for the edge switch region. We just talk about the importance of this region. It's very important for the BCL related to blood cancer type, and we involve this region, and also some non-coding variation, but maybe it has function with the blood cancer. So we give you this tube, the DNA tube, which is based on the DNA template. But just as I said, some kind of like the fusion, they will most happen in the intron region. We know that the intron region is very large and it will have some repeated region. So if we want to, based on the DNA template to design the probe, it will maybe have some problem. The first one is that the region is very large. So if we want to cover them all, the cost will be very high. And the second one is that it will have a lot of the repeated region, which means that maybe it will be very hard to design the probe to cover this region. So it will, if we want to involve that, it will have the risk of the off target. And the third one is that sometimes maybe based on the DNA template, we see that maybe there is some like the gene fusion happened, but maybe it don't have the function. So it has no meaning if we just check with this kind of the variation information. So based on this one, we we have the DNA tube. So it based on the RNA template, and it covers the 146 genes, the UTR and the 4CDS region. And beside, we involve the VDJ recombination, the IGTR probe to check with the recombination, rearrangement, and such kind of the abnormal situation. So with the RNA tube, we can check with the fusion information, and we can also check with the RNA expression level to check whether this kind of the fusion have the function. It will have some protein, new protein just will expressed and have the further function with this kind of the blood cancer type. And for now, actually, this kind of the panel can use for the diagnostics classification, and it can combine with check with different kind. Just as I said, this panel we involved the most common blood cancer type and involve different kind of biomarker inside. So this kind of the panel can used for the different kind of the malignancies, the hematological malignancies, combining diagnostics. And with the variation information, because we based on the bioinformatic analysis result, we can see that some kind of the variation may be related to the pathogenic. Maybe it will have the high level with the pathogenic, this kind, and maybe already have a lot of database. It will have the drug therapy information. So with that kind of information, we can get the treatment, etc. And here we show you some detailed information with the gene list. This part, it will be related to the CDS region based on the DNA template. And for the DNA tube, we also have involved some selected intra-region. Just as that, we see that the ALK and the MYC will be such kind of the genes will be very important. And beside of that, for the RNA tube, we also involved a lot of genes, just as I introduced to you. And because we know that this is a commercial panel, we based on the different kind of database, different kind of the guideline and the expert consensus, and we can check first if the genes involved in this panel can meet the requirement or not, or we also can involve more biomarkers inside. It will be very flexible. And beside of the basic information, we would like to show some the performance with this panel to see whether it can give you the reliable variation detection result or not. So this one we performed with this DNA tube, and we use some samples already contains a different kind of the variation, and we have the references allele frequency. And we performed it on different platforms like the MJ and Illumina. And this one is our observed result. And you can see here the result will be very consensus with the references value, and the negative control won't have the false positive result. So this is with the DNA tube, and with the RNA one, we also use some the sample with the fusion information inside, and we use the RNA tube to check with the variation information, and we also can get to see if such kind of a fusion just happen a lot. So for the commercial panel, actually we have build the pipeline based on the DNA tube and the RNA tube. We have the different kind of pipeline, and we will use this. We can analyze the result on this pipeline, and we can check every mutation information and use the IGV or other kind of plot to check with the detailed information to have the double check whether this kind of the result will be the true variation or maybe it's just a background noise. So beside of this panel, the HEMA panel, we also give you another, the Mucala AML panel. So this panel actually it's based on the patent technology. So for now, on the market, the probe is the traditional one. It's 120 anti-probe. So with the long length, maybe it will have the trouble. Maybe if the panel size is not so many probe inside this panel, it will have some trouble with the on-target rate, which means that sometimes maybe a lot of the raw data will just waste during the analysis process, and only a few of the data can be used, and which means that it will have the high cost and a lot of the waste information. So give you this Mucala patent technology. It will have the shorter problems, and with the shorter problems, it can combine with the target with shorter time, which means we can reduce the turnaround time we can, from the sample to the result, we can just use a shorter time. And besides that, with the special design, the after the target the fragment, it will also combine the probe near it. So by this way, we can make sure the combination will be very fast and fixed. And combined to the traditional one, we can increase the on-target rate, which means that in the MRD detection situation, we can just reduce the sequencing data cost. So based on this technology, we give you this Mucala AML panel. So this panel also refers to a lot kind of database, like the COSMIC and the TCGA and other kind of clinical guideline. And here is some the biomarkers we selected for this panel. And this panel, most of the we can see that we have do some kind of the research, and we see that approximately 90% of the cases, it will contains at least one mutation, the followed mutation, and about 60% of cases has the 3 or more mutations. So this can be used for, also can be a tool, can be some kind of products use the MRD detection situation. And here we also, just as I said, this kind of the Mucala technology can increase the on-target rate. And it will have the more stable result based on the hybridization experiment. So in here, we show you that this is the deep blue color is the Mucala technology. We can have the higher on-target rate, so we can reduce the raw data will reach the same effective sequencing depth, and the on-target rate will nearly the exceeding 70 or 80%, and they are more stable across different batches. And besides, we also had checked with the performance with some we simulate with the samples with the references variation to simulate different kind of variation information. And we have made the comparison with the Mucala technology compared to the traditional one. So after we check with the average depth, after we flirt with we have to do the consensus analyze after we flirt with the background noise as much as we can. You can see here the mutation. The Mucala technology can support a higher average depth and have the more rate supporting the mutation compared to the traditional method. So this actually for now this kind of has been the clinical laboratories and some kind of the company use this kind of technology for the MRD detection. And here it will be similar for with the demo report for the HEMA panel and the AML1. C part with the on-target rate, the most important parameters related to the hybridization experiment, and we have the summary with the information we have detected with the pathogenic, pathogenic, and no clinical pathogenic variation information. And we will also have list the variation, detailed variation, each kind of variation information with the allele frequency and the detailed the mutation, the SMP size, etc. To have this kind of we will list here, and after that we will do such kind of interpretation based on just as said the ACMG database, CLINVA database, and other kind of the references database to do the interpretation to say whether this kind of variation will have the function and which kind of function they will have to give the direction, give the information for the further treatment and maybe for the drug therapy or the immune therapy, etc. So actually, in summary, here we want to say that the NGS for now has placed a very important role in the tumor different kind of the solid tumor or the blood cancer, combining diagnostics and also MRD detection. And here we want to provide to you this kind of tool, this kind of technology to help you to get more reliable and more precise result in this kind of the critical situation. So this is all the information I want to share with you today. Thank you.
Thank you so much, Yang Chen, for the great presentations. Finally, we have complete 4 presentations, and give applause for all the speakers. And we have invite all the speakers to join with us for the discussion sessions. Baik, kami mohonkan Prof. Yeti dan Dr. Cilmi untuk bisa naik. Baik, kami berikan kesempatan kepada audiens, Prof, Dokter, apabila narasumber kita ada 4, mohon diangkat tangannya dan menyebutkan asal instansinya dari mana, nama dan asal instansi, dan pertanyaan ditujukan untuk siapa. Baik, kami berikan kesempatan. I give the audience the opportunity to ask the questions. Any other question from the professor, Dr. Consultants, or all the audience? Okay. We are waiting. Oh, okay. Thank you.
Good afternoon. Thank you for the opportunity. My name is Andrea. I am from Atmajaya, Jakarta. I would like to ask a question to Ms. Lee Sering. I want to know that is karyotyping can help diagnose hematology malignancy in the case of there's an aberrant expression of the CD markers, or mostly we use karyotyping for prognosis only.
Okay, Dr. Lee, you have the questions?
Yeah, okay, thanks. The answer to that depends on what kind of disease that we are referring to. Do you have an example? AML?
Yeah, maybe in AML, maybe.
Yeah. So for AML, I think if we want to make the correct classification, because AML is very diverse, it is like many different outcomes for one disease. So I think basically what people are going towards is refining the diagnosis of AML. It's not just saying, oh, you have AML anymore. Yeah, that's important first step. However, for treatment, for if things are going to make a difference to the treatment, then we need to refine AML, what subtype of AML. And so that goes into the WHO concept. So the WHO concept is trying to say that AML is many different diseases. Can we be more specific what kind of AML the patient has? So cytogenetics and molecular is important to answer what type of AML the patient has nowadays. So like what Prof. Yeti presented, the AML diagnosis in WHO, there's the genetically defined acute myeloid leukemia. So for example, the 821, AML with 821, AML with inversion 16, AML with, I can't remember others of the 6-9, translocation, etc. So I think cytogenetics is nice to have to define the type of AML that the patient has.
So we not only differentiate between it is AML M1, M2, but we also know that this specific AML we need to treat with this specific treatment. That's cytogenetic.
Yes, to a certain extent, yeah. But I would say that for treatment, most of the AMLs will just start off with the same treatment, 3+7, then HiDEC. It's only if the patient has got very poor risk cytogenetics. So for example, complex or MM or the 11q23, then after the initial treatment, we will send them for a bone marrow transplant. Otherwise, the AML will relapse very quickly. Without with just chemotherapy alone, the AML will relapse very quickly. Whereas if you have a 821 AML, you can just chemotherapy alone and the patient is cured. Then you don't have to send the patient for a bone marrow transplant, for example. Low risk of relapse.
So we can predict if it's probably be relapse or not too.
Yes,
So,
yes. Okay.
Thank you. Thank you so much.
Thank you so much. Thank you, Dr. Lee. Any other questions? Ada pertanyaan yang lain? Kami persilakan.
Mau bertanya sama Dr. Cilmi, dalam pemilihan parameter untuk flow cytometry, karena kan ada beberapa parameter yang M2 dan M1, yang gambaran bagaimana dok supaya kita tidak boros gitu langsung tepat sasaran, kita pilihnya M1 atau M2, gambaran di BMP-nya kira-kira yang bentuk bagaimana untuk memilih parameter tersebut, panel-panel untuk flow-nya.
Pertanyaannya bisa ditangkap, Dok?
Ya, makasih.
Ya,
Dengan
silakan.
Dokter siapa nih? Dokter Suyanti, ya, makasih. Ya, jadi memang nanti besok kita akan pakai clear lab ya. Clear lab Beckman itu punya 4 panel, B panel, T panel, M1, M2. M1 itu fokus ke arah monocytic lineage ya. Kalau M2 fokus ke myeloid. Jadi kalau kita petakan, semua panel ini punya CD34, jadi punya CD34 semua. Nanti bedanya kalau di M2 punya CD19, 38, 117, kemudian 33, 13 ya. Kalau yang M1 itu monocytic punya 64 backbone-nya, kemudian 14 untuk lihat maturitas dari mono, kemudian 16, 11B, HLA-DR, sama 7 dan 10. Ya. 7 sama 10 penting untuk lihat aberran. Nah, kapan kita tentukan pemilihan marker, apakah M1, M2 duluan? Nah, umumnya maksimal. Kapan kita tentukan panel? Pertama kita lihat morfologi dulu. Morfologi itu seperti saya sampaikan di depan tadi sangat penting. Kita nggak bisa ninggal morfologi. Jadi morfologi nomor 1 kita tentukan blastnya berapa ya dari sisi morfologi. Kemudian yang kedua adalah subtipe dari morfologinya. Apakah monoblastik, promonosit atau monosit matur itu berapa persen. Kemudian myeloblastnya berapa persen. Kadang memang agak sulit ya, beberapa kasus itu myeloblast yang mirip monoblast gitu ya, atau sebaliknya ya. Nah, kita hitung dulu semampunya. Kalau dua-duanya lebih dari 20%, ya berarti kan kita juga M4 ya. Nah, kita idealnya sih pilih M2 dulu. Karena ada beberapa kasus myeloblast mirip mono. Jadi kita biasanya saya pilih M2 dulu. Kalau M2-nya muncul CD34 positif, CD45 dim yang menegaskan itu satu blast, kita lihat marker 117-nya. 17 itu biasanya kebanyakan di myeloblastik ya. Bisa juga di mono, cuma yang mono yang seri yang imatur sekali ya. Kalau yang monomatur biasanya 117 sudah hilang. Nah, kemudian kita lihat posisi 64 kalau ketemu yang mono tadi kita pakai M1. Jadi kalau ketemu monomatur misalnya ya, monomatur meningkat ya lebih dari 20% atau total dari monocytic lineage, monosit matur tambah promonosit tambah monoblast lebih dari 20, kita tambahkan M1. Ya, untuk definitif lebih menegakkan bahwa memang ini ada mono. Nah, kita kan perlu menghitung berapa persen myeloblast, berapa persen monositiknya. Dari situ pemilihnya seperti itu. Jadi kita lihat tetap morfologi dulu yang utama.
Pertanyaan selanjutnya dok, kami kan baru alat itu. Menurut pengalaman dokter, apakah kita harus memesan sama banyak M1, M2 atau cukup yang paling banyak pengalaman dokter yang banyak kasusnya M1 atau M2?
Jadi dari 4 panel yang paling jarang itu T. T-cell itu sangat jarang. Kita hampir nggak habis-habis regennya ya, satu box nggak habis-habis. Yang paling sering habis itu M2. Kenapa M2? Karena di situ ada CD19. CD19 ada, Kemudian ada CD117 untuk myeloblastik. Jadi itu yang paling cepat habis M2 biasanya. Ya, saya pakai M2 dulu. Kalau di M2 kita misalnya bingung ALL yang tipe L2 kan mirip banget sama M0 ya, secara morfologi ya. Nah, itu saya pilih M2 dulu. Minimal mengarahkan 19 negatif, 17 positif, ya sudah saya langsung nambah 34 yang blastnya juga memang confirm itu blast 19 positif, saya tinggal nambah panel B. Jadi mainnya di M2 paling banyak terpakai, habis itu B panel. Pengalaman kami juga banyak mendapatkan kasus limfoid ya, sehingga B panel itu juga cepat habis. Jadi kalau di kami sih M2 sama B ini memang harus sedia lebih banyak daripada M1 sama T. Jadi urutannya mungkin M2 dulu, kemudian B, kemudian M1 terakhir T, seperti itu. Tergantung nanti kalau mungkin tren penyakitnya bergeser ya mungkin kita harus strateginya dirubah ulang gitu. Terima kasih.
Ya, makasih banyak dok.
Terima kasih. Baik, silakan disebutkan nama, asal instansi, dan ditujukan untuk siapa.
Selamat sore, saya Domin. Jadi pada kasus keganasan hematologi dengan lebih dari satu jenis mutasi klon, apakah flow cytometry itu mampu mendeteksi bila ada 2 atau lebih daripada populasi klon tersebut? Terima kasih.
Baik, silakan Prof. Yeti.
Iya, dokter siapa dok?
Dominik.
Dokter
Dominik.
Domini. Dominik, ya terima kasih dokter Dominik. Ya betul ya, jadi kalau yang namanya ada klon gitu ya, ada suatu mutation yang membentuk klon gitu ya, itu biasanya dia mempunyai ciri spesifikasi tersendiri. Misalkan limfoblast gitu ya, ada pada CLL gitu ya, itu kan ada klon tersendiri yang dia akan mengekspresikan CD5 yang seharusnya dia tidak terekspresi. Jadi klonnya di situ ada CD5 positif, CD23 positif, 200 positif, nah seperti itu. Kalau itu ada lebih dari satu klon, dan yang saya katakan tadi klon itu akan mengekspresikan spesifik marker, maka dia akan mendeteksi. Apalagi kalau di dalam populasi yang kita getting itu lebih dari satu populasi yang padat gitu ya, yang menarik gitu ya, yang akan kita tuju gitu ya. Nah itu jelas itu ada 2 populasi.
Baik, terima kasih.
Terima kasih juga.
Baik, terima kasih Prof. Yeti, terima kasih Dr. Moon. Any other questions? Oke.
Thank you for the opportunity. My name is Tri from Dermais. I have a question for Dr. Lee Siring. In the slides highlight that AML with PDC is distinct from blastic plasmacytoid dendritic cell neoplasm. Is in a borderline cases with high CD123 and HLI-DR expression, what is the best diagnostic threshold or marker combination that can help us to definitely separate between these 2 diagnostic? Thank you.
Do you have your question? Yes.
Yeah,
Please, Dr.
thank you, Dr. Tree. Yes. So I think your question is differentiating the blastic plasmacytoid dendritic cell neoplasm, BPDCN, from AML with increased PDC. Yeah. So the first thing on the morphology and the flow is that for AML with PDC, the classic criteria of myeloblast must be 20% or more. Then secondly, if we look specifically at the PDC subset, in the BPDCN, the PDCs are neoplastic and they are usually CD56 positive, CD4 positive, and CD123 positive. And whereas for the AML, with increased PDC, the PDC tends to be CD4 negative and CD56 negative. So it doesn't have the aberrant CD56. It's just an expansion of the population, but with quite a what we call usual phenotype. In both cases, the CD123 will be quite bright because CD123 is the one of the cytokine receptors that is just a marker that this is PDCs. It doesn't differentiate both. Hope it answer your question.
Okay, thank you, Dr. Lee. Any other questions
May
from
I,
the
Dr.
audience?
Gumang? May I, Dr. Gumang?
Oh yes, of course, Propriety.
Yeah, my question addressed to Dr. Lee. Yeah, about the we have so many patients with CML. Yeah, and also among them, the CML will go to that this CML will progress to the plastic crisis in the initial diagnosis. What is, according to your experience, what is the co-mutation, yeah, in the patient with the CML, yeah, beside the PCR IPL, that the patient will progress to plastic crisis?
Question. Yeah, good question. Yeah. So a couple of things. So for the CML, it depends on firstly, there is if the cell genetics will help, all right? So if there is additional chromosomal abnormalities in the CML positive cells, that is a classic sign that it is an accelerated phase. So for example, if we do the karyotype and there's 920 translocation 922, but in the cell with the translocation 922, there is a additional monosomy 7 or a deletion of other chromosome abnormalities, then it is an accelerated phase that predicts that is that if they are CML in chronic phase, and we do a flow cytometry, and we find that the B lymphoblasts are increased at more than 5%, that is a very high chance that the patient will become the B lymphoid blast crisis very soon. Yes. So we actually had one case before that on the diagnosis, actually the B lymphoblast was about 6%. So morphologically, it is like a chronic phase. But the patient developed B-ALL within 6 months of the diagnosis.
Okay. Okay.
So
Yeah, I see. So the additional abnormalities genetic, yeah, additional
Yes,
abnormalities
yes.
genetics is in the initial,
At the initial diagnosis, yeah.
not that in the progress in the journey, the patient also have the additional mutation.
Yeah, so some of them, when they present, they already have additional cytogenetic abnormalities. So that actually puts them into the accelerated phase.
Okay, thank you, Dr. Lee.
Dr. Lee, thank you, Propriety. Unfortunately, due to the limited time, we have to conclude our discussion today. Give big applause to all speakers. Today discuss has highlighted one of the important message. Modern hematology is no longer based on a single technologies. The greatest value come from integrated information from different diagnostic platform and translating into the clinical meaningful decisions. Okay, thank you so much for all the speaker. Thank you so much, Dr. Lee, Yang Cheng. Terima kasih Prof. Yeti, terima kasih Dr. Cilmi, berikan tepuk tangan yang meriah. Waktu kami kembalikan ke pembawa acara.
Terima kasih. Terima kasih kepada moderator serta seluruh narasumber atas pemaparan materi dan diskusi yang sangat komprehensif dan membuka wawasan. Semoga ilmu yang telah disampaikan dan pengalaman yang telah dibagikan pada kita semua pada workshop flow sitometri, sitogenetik, dan NGS Izinkan kami mengundang para narasumber serta moderator untuk berkenan maju ke depan panggung untuk menerima souvenir. Kami persilahkan Profesor Dr. Yeti Hernaningsi, Spesialis Patologi Klinik, Subspesialis Hematologi Klinik Konsultan, Dr. Syahrul Silmi, Spesialis Patologi Klinik, Subspesialis Onkologi Klinik Konsultan, Magister Biomed PhD, Dr. Lee Ying, Dr. Yang Chen PhD, serta moderator kita, Dr. Komang Agus Trisna Amijaya, Master of Medical Science, Spesialis Patologi Klinik. Kepada para narasumber dan moderator, kami persilakan untuk berkenan mengambil tempat di depan panggung untuk mengikuti prosesi penyerahan apresiasi. Kepada Dr. Syahrul Cilmi, Spesialis Patologi Klinik, Subspesialis Onkologi Klinik Konsultan, Magister Biomed PhD, selaku Ketua Panitia Suramadenusra, kami persilakan untuk berkenan menyerahkan souvenir. Kepada para pembicara dan moderator dipersilahkan untuk foto bersama. We would like to invite the speakers and moderator to take a group photo together. Kepada para pembicara dan moderator dipersilahkan untuk kembali ke tempat. Sekali lagi kami ucapkan terima kasih atas kontribusi dan dedikasi yang luar biasa. Once again, we would like to thank you for your outstanding contribution and dedication. Hadirin yang kami hormati, selanjutnya kita akan mengikuti industrial simposia yang dipersembahkan oleh Beckman Coulter Life Science yang diwakili oleh Mr. Tony Lee. Let us introduce Mr. Tony Lee. He is a flow cytometry application specialist at Beckman Coulter Life Science with a background in medical technology and biotechnology. He has more than 8 years of experience in flow cytometry, supporting laboratories, hospital, and research institutions across Southeast Asia. His main expertise include clinical flow cytometry, leukemia and lymphoma, MRD detection and monitoring, and immune monitoring. He also has experience in user training, technical support, and workflow optimization. With his experience and expertise, we would like to invite Mr. Tony Lee to deliver his presentation.
Thank you for your introduction. Good afternoon, everyone. Are you tired? Yes? Headaches? Yes? Okay, so I have good news for you. So my presentation will be the last part of the workshop. And today I will introduce to you about our Diagnostics, our flow cytometer and the ClearLab solution. Is the powerful and more useful for the lymphoma and leukemia diagnostic. And as you know, as Biometrics, we have a long history of the flow cytometry. Our journey began like 15 years ago in 1970 with the first, with the EPIC 2 is the first flow cytometer with the laser-based in the world. And after that case, we still develop and innovate, and we introduce more solution and more instrument. And in 2014, we introduced our cytoflex flow cytometer. It's the first ABD technologies flow cytometer, and it's know about the more sensitivities flow cytometer, and we apply these technologies for our other product. We call it the Flex family, like in the Cytoflex SRT, Cytoflex Nano, and the DX Flex for the diagnostic. And come with the Lab 10Cs, we have the like comprehensive tool for the LNL diagnostics that I will walk you through later. And okay, so this is a GI flush flow cytometer. You know that in the past, right? When we begin with like the one laser, two laser, and maybe only have 2 or 4 color panel for LNLs. It's more not complexities. But right now, our panel like expand to like 8 color, 10 color, or even more. So that means the panel setup and the conversation workflow is more complexity and like more difficult. So that's why our GX Flex flow cytometer come up and to address the issue with more color without adding more concern. And you can see here, this is our the illustration of the DX Flex. And so first, you can see that we have more information in one tooth because it's up to 13 color now, and it will help you simplify the conversation procedures. The second thing is with the ABD technology, which known as more sensitivity, so you can help you like separate the dim population, the dim expression marker from the negative population. And it's very, very important in the LNL diagnostic and also in MRD. And the last one you can see it's very like compact and it's not required, no need compressor card like other flow cytometer, so it saves your lab space. And when we look inside the flow the DX Flex, you can see here I call it is the heart of the DX Flex. I cannot use the laser point because it's the Pemba filter, and in the behind is a ABD detector, the avalanche photodiode detectors. It's very small. It's like a LED purple. And when you compare the ABD technologies, ABD detector with the traditional PMT, which is most used in the traditional flow cytometer, you can see here in terms of quantum efficiency. You can see here is in the blue line is ABD and the red line is a PMT. So the quantum efficiency of the PMT will reduce, especially in the longer wavelength compared to the IBD. The efficiency still keep like more than 18%, even with the longer even in the long wavelength, more than like 800 nanometers. And you see here when we compare to some like dim population marker, so the IBD will like show the more sensitivity. We can separate the dim population from the negative population. And the second thing, when we compare the IBD and PMTs, you can see here is about the linearity. You can see in the below is in the IBD the gain and all the voltage, when you set up the instrument, right, you need to set up the gain or the voltage of the panels of the experiment. And you will see in the fluorescent, the MFIs, the fluorescent intensity is linear together, right? When you change the gain or the voltage, so the instrument will know which the fluorescent intensity you can guess. Compared to the PMTs, it's not linearity, so it will help you so much in the compensation procedure. So you can see here is a traditional compensation setup procedure. You set up the voltage for the channel, right? And then you acquire the single color stain, calculate the compensation matrix, create the experiment, and then you import the compensation and matrix into the experiment, and then you acquire the mixed stain sample, and you will analyze the data. But the point here is when you analyze the data, you feel it's not good, not what you want, you say then you want to change, you want to increase the voltage, or because some channel is quite dim, or you decrease because some channel is like overexpressed. So what's next? You had to do the compensation again and again, right? You had to acquire the single tube again and to run the new compensation and then apply for your new setup. And usually it's a bottleneck here, it's a pain point here that you had to do the compensation several times to get the final optimal setup. But with the DX Flex, it's more simple because the compensation metric, you can save it. You just do it one time, you save in the library, and then every time you set up the new application, the new panel, you just import the compensation from the library. And every time you change the gain from your panel, so the compensation matrix will automatically just adjust the compensation automatically will be like it will recalculate automatically, so you don't have to acquire the compensation tube again and again. Just import, and every time you run, you want to change, you just change again, and the compensation will recalculate automatically, right? It's more simple, it's more efficient, yeah. And about the DX instrument configuration, we have several configuration here, from 1 laser 5 color to 3 laser 13 colors. So, and it's enable to upgrade. If you like at the first, you don't have run LNL, or maybe you just run like CD4, CD3, CD4, CDS for like maybe HIV or something. So you can use the lower configuration, but later when you run, you you want to run LNL, so you can easily upgrade your instrument to 1 laser to 3 laser, 13 colors. And the JFlex also come with the autoloader, so it's we have the carousel in the autoloader. It's a 32 position, so you don't have to wait. When you acquire the sample, you don't have to waiting, like unload the sample, waiting the acquisition, and unload for the next tube. It's all, you can put all the tube in the carousel and just click pull your panel and just click run. And the tube also had the sample ID and the barcodes for the management. And the next here, with the DFlex, we use the SciExpert software, and it's one important thing is a instrument software, but it's working offline, so it means that you can install the software in your own PC, your own laptop, so you you don't have to work, you don't have to sit in front of the instrument to do the analysis. You just copy the data and put it in your PC, so you can open and analyze it in any way you want. And the software also can enhance the rate event with up to 25 million event per file, and the flow rate can up to 13,000 event per second, so it's very fast and it's very helpful, especially like in some MIDs analysis, because you have to acquire a lot of event, right? Maybe 1 million, 2 million, or even 5 million event. And the JFrog also had the connectivity to the LIS directly. So you can no need the middle software between the instrument and the LIS anymore. And for the IVD assay, we have the ClearLab. I will introduce to you later. And so with the DI-Flex flow cytometer, we help you to address the S-squared of the lean process in the clinical flow cytometry laboratory. And I go to ClearLab, our solution, ClearLab 10C system. I call it all the pieces are in one place. Why I say that? Because we provide the comprehensive all the material you need for the one IVD flow cytometry test. So first, for the instrument setup, we have the compensation setup kit with a single color, and we also provide the ClearLab 10C bits in case that you do the compensation, but you don't have like the sample with the positive population for the compensation, so you can use a ClearLab compensation bits. And we also provide you the controls. We have the ClearLab control, the normal and the abnormal. It's very important for the IVD test. We have 2 levels. And the next one is the first LNL application specific normal and abnormal IVD control. And in ClearLab, we have 4 tools, and for Linux, T cell, B cell, and M1, M2 cell. So you will have chance to do and expose to it tomorrow, right? And this is all the marker, all the necessary marker for each Linux. Like for example, in the B cell, we have here we have the CD45 for this common marker for leukocyte, for all the leukocyte, and we have progenitor marker like CD34. And for example, in the B cell too, we have like lineage marker CD19, CD20, the clonal marker like kappa and lambda. It is same in like T cell and M1 and M2. And also if you key on the lymphoid only, we have the ClearLab LS, is the lymphoid screen. It's pretty much 12 marker inside the tooth, right? It's all the marker here. We stack the kappa and lambda with the CD4 and CD8 together, so it's expand to 12 marker in 10 color. And after the acquisition on the DX-Flex, you can analyze and report in the Calusa software or Cyber software. So with the Calusa, we have the predefined template. So it helps you reduce the time of the analysis. You should drag the templates, and you will drag the data file into the template. So the software will generate automatically generates the report and the result for you. And for the training and education, we also provide the ClearLab 10C and ClearLab LS cables. It's include like all the typical case, like for AML, BALL, or TALL, or also like, for example, here in the case, I just shortcut in the casebook is typical CLL case. You can see here CD19, CD5 double positive, and it expressed the CD200 with a lambda rejection. And if you keen on the MRD, right, we also had the Duracon RE panel. RE means stand for the rare event. So we have the CLB is for the chronic leukemic B cell, BC for the plasma cell, ALB for acute leukemic B cell, and AML1 and AML2 for the AML MID. And sorry, I just want one thing here. You can see we have some empty channel here. So the purpose of the empty channel is for the user, so you can drop or you can add the more marker here in the empty channel, because you know that in the MRD each patient may be spread some different apparent marker, so it's very useful for the in the MRD. So every patient you can decide what's the marker, apparent marker you can add into the Duraclone tube here. And see, this is just a sample in the AML M1 tube in the whole plus sample. So you can see here have like the red population is a black population, can separate very well with the other population and spread the progenitor marker and immature markers. This is in the AML2, also with the same patient sample. And in this case, you want like design your own panel. So we have the service called Lucid Custom Design. So we can help you like design your own panel. You want to do the cocktail, you want to do the dry tube with your own panel. So we can help you to design your panel. And it's also like premix is same like Duracron or Killer, but the panel design is based on the customer based on use. So you can, if you want to create your own panel, so feel free to discuss with us. And so for the LDT workflows, I run out of time, but I just only like few slides. So you can see here, if you do LDT workflow, you have to do many things: panel creation, method validation. You do the stability testing, but it's had a lot of like time consuming and also like error prone. So with our solution, we you don't have to do it anymore, because we already do the validation, and we already have you to create your panels. So with the Collab 10C workflow is more simple. And again, our solution and our innovation focus on avoiding process waste in the flow lab. It's a defect, overproduction, waiting, non-utilized talent, and transportation, inventory, motion, and it's processing. So it stands for avoiding downtime for your workflow. And all other additional resource and material, you can go to wayman.com. We have the K-book, we have the training, we have the webinar on our website. And okay, so before I end my presentation here, I have the like short survey. So please scan the QR code and fill out the survey. Thank you so much. Thank you.
Thank you, Beckman Culture Life Science. Next, let us watch the sponsor video once again. Hadirin yang kami hormati, tidak terasa seluruh rangkaian kegiatan workshop flow sitometri, sitogenetik, dan NGS telah kita lalui bersama. Kami menghimbau pada seluruh peserta untuk mengerjakan post-test melalui akun LMS masing-masing. Bagi peserta yang mengalami kendala pengisian melalui LMS, dapat menghubungi panitia di meja registrasi untuk mendapatkan bantuan. Kami informasikan bahwa makan malam dapat diambil di luar ruangan. Selain itu, foto booth telah disediakan di lantai 1 dan dapat digunakan untuk foto bersama. Kami mengucapkan terima kasih yang sebesar-besarnya kepada para narasumber, moderator, sponsor, panitia, serta seluruh peserta atas partisipasi aktif dan antusiasme yang luar biasa. Semoga ilmu yang telah diperoleh hari ini dapat memberikan manfaat serta mendukung praktik klinis khususnya di bidang diagnostik hemato-onkologi. Kami mohon maaf apabila terdapat kekurangan selama acara berlangsung. Akhir kata, saya Pauline undur diri. Terima kasih atas perhatian Bapak dan Ibu. Selamat sore. Wassalamualaikum warahmatullahi wabarakatuh.